My name again is Kamran Sadr. Thank you, Dr. Reddy. I'm coming from Kaiser Permanente, Northern California, and the Fremont San Leandro Medical Centers. Before I get started, I'd like to thank Dr. Navarro and Dr. Hall for inviting me to speak today. My talk is entitled Average Arthroplasty, and really what I want to take a look at is really our paradigm, our mechanical alignment paradigm, and give you the viewpoint from a kinematic surgeon on what I used to do as a measure resector and gap balancer, and maybe provide some learning points for everybody. I have no current disclosures. Ultimately, when we look at the literature, we have a fairly standard idea of what our patient satisfaction, dissatisfaction numbers are. In this paper by Bourne et al., he reported 20% were dissatisfied, and really the rate of dissatisfaction is largely determined what questions you ask. And there are multiple papers internationally which look at this and have generated a fairly consistent number of anywhere from 10 to 20% dissatisfaction with our patients. And with some papers, interestingly, highlighting preoperative deformity as a risk for dissatisfaction, as well as also a risk for revision surgery. Before I get any further, my initial goal here is just to really look at alignment. And I want to delineate that from looking at specific cutting techniques. I was a fellowship-trained measure resector, changed to gap balance early into my practice, but that's not what I want to talk about. What I really want to talk about is the goalposts, the alignments that we're shooting for. And I was initially shooting for mechanical alignment, and a lot of these cuts are made initially, actually, before I was making measure resection, I was making a distal femoral cut based on varus valgus knee, same with my rotation, and I was always shooting for a neutral mechanical axis of the tibia at 90 degrees for my 2 base plate. Just to give you a little backbone, as a total joint surgeon, I entered an area where I have about 90% Asian population, and I was struggling initially with a rather high amount of outlier anatomy with my own practice. And so I kind of went through metamorphosis early on, and then I encountered some of the works of Dr. Howe and also Dr. Bini, and slowly I started moving toward kinematic alignment as my goalpost. Just to further clarify things, because I think we get lost when we're looking at alignments and sometimes confuse it with techniques. Measure resection and gap balancing traditionally are looked at and used for shooting for mechanical alignment. But actually, Dr. Howe's caliper technique is actually one of the most pure versions of measure resection out there, but it shoots for kinematic alignment as opposed to mechanical alignment. And then recently I proposed a paper called Linked Anatomic Kinematic Arthroplasty. And what that does is it uses gap balancing techniques to gain the same goalpost, which is kinematic alignment. When we look at our cutting techniques as whole, we have to understand that the knee is really made of 2 major entities, which is the bone and cartilage, and then the ligamentous structures, which provide the natural law or the kinematic law of the knee. But the majority of our cutting technique is reliant on only bony anatomy. I mean, when I was doing measure resection, I used distal femoral cut and the proximal tibial cut. I referenced that off the bone. Same thing with the posterior condylar axis. Pretty much everything in measure resection, as well as also to a certain degree, even in the calipered kinematic knee, is referencing and measuring off the bone that we're measuring. I want to highlight gap balancing because gap balancing is unusual because it actually is one of the few techniques which uses the ligamentous anatomy to determine the position of our implants. So when I look back at my own practice, I found several problems with my own paradigm, and what that was maybe possibly shooting for the wrong goalpost, which is mechanical alignment. I also realized that my technique was shooting for essentially a law of averages. I was shooting for an average set of anatomical variants, and then had problems when my patients fell outside that average. I found that there was a fair amount of imprecision with the cutting jigs I used, especially with the older systems. And then I also found it interesting that whatever I did with the femur didn't seem to affect the tibia. There was a lack of linkage between what we were doing. And then lastly, I always had a problem with ligament releases and always didn't like doing them. And so I found that as ultimately not necessarily the best way to help my patients. So to go through these quickly, mechanical alignment is well established in the literature that a neutral coronal alignment is something that could reduce possible failure. And just to this point, Fang et al. In this paper highlighted that a well-aligned knee was better for longevity. But this tenet, this basis for our paradigm has come under scrutiny and criticism. With, for example, this excellent set of articles, there's more than one by Parte out of Mayo, looked at the 15-year survival of two cohorts, an aligned group and an outlier group, the outlier group being greater than 3 degrees from neutral, and found that the aligned group did not necessarily improve the 15-year survival rate. And his most recent paper even has a longer survivorship data. As we move on, we look at anatomical variation, talk about law of averages. We have to understand that every decision you make within a total knee is basically applied to some form of variant anatomy. The question is how variable is the anatomy? And when there is a lot of studies looking at individual anatomical curves. And here, this paper by Deacon looked at the femoral mechanical anatomical angle and found ultimately that there was quite a variation. It found that if you went with a fixed valgus resection, like I was doing previously, of 6 degrees, that you were off from neutral greater than 1 degree 25% of the time, a quarter. Same thing with a paper out of Scripps. This is by Merrick and Bugbee. And this looked at both the distal femoral angle as well as the femoral rotation. And they found that the incidence of outliers, the distal femoral valgus angle, was greater than 13%. And they found that with the femoral rotation, that there was an extensive range with patients having as much as 3 degrees internal rotation all the way to 11 degrees of external rotation. But the average femoral rotation was 3.3. We look at precision of the guides that we use to make these cuts. This has also been heavily studied, just a few of them here. Cates et al. Looked at the precision of IM guides and found that they can lead to malalignment of greater than 3 degrees up to 20% of the time. Reed et al. Looked at the anatomical axis and where it came out relative to the mechanical axis and found that it actually exited the distal femur 6.6 degrees medial to the notch. But a lot of us still use the notch to actually place the initial starting point for our IM guide, which could potentially put us in a different position than we intended. Lastly, with Laskin et al., he reported 90-degree accuracy with intramedullary guides, but found that with his obese patients or patients with stove-type anatomy or wide intramedullary canals, the accuracy fell to 72%. So to highlight the concept of lack of linkage, to go back through, I used to make a set distal femoral cut and then a set tibial cut, and you can see in this loose guide here that this could lead to possible medial lateral imbalance and extension. And to give another example here, if I made a distal femoral cut of 5 degrees and then 90-degree cut of the tibia, and then flexed the femur up, and then made a standard 3-degree rotational cut for my femur, you can see this could possibly lead to a tight lateral space in my extension and then a tight flexure space on the medial side. And then the only way to overcome this then is to then possibly release the ligaments. And even though there is a common thought in literature that supports that doing some form of ligament release can help you get out of a imbalanced knee, the truth is the reason we're doing ligament releases is to increase the scope of the current technique you're doing. So if this yellow rectangle represents the inclusion zone of my technique relative to an anatomical curve, by doing a ligament release, you're hopefully catching a little bit more of the anatomy which your technique will accommodate. So if we look at all anatomy and assume that all of them has some form of anatomical curve, it eventually turns out to look a lot like a bell curve. And here, if we look at the distal femoral angle, and then I did my measured resection technique, and it had a specific inclusion zone, it accommodated the average very well, as long as your patient's anatomical feature, in this case, let's say I had a patient that had 5 degrees of distal femoral angle, as long as they had that and it fit what I was doing, it probably worked out well. But then your outliers would fall somewhere else on the curve. And so the problem is compounded by the fact that every decision we make pretty much represents a different anatomical curve. And so in this case here, for example, I have patient A, all parts of their anatomy seem to fall within the technique I did. This is probably the very satisfied patient I had in my practice. But typically, we would have a patient that had maybe a few aspects which are outside the curve. And these are the patients that maybe were somewhat dissatisfied or satisfied. But you did a little physical therapy, after a year, they got better. But really, when you talk about outlier anatomy, you're probably talking about multiple aspects of anatomy and outside the spectrum of the technique you're applying. And in my practice, these were the patients that were dissatisfied. And ultimately, I concluded that the subjective and objective outcome of the knee arthroplasty is reliant on the specific technique's ability to accommodate the anatomical variance in a cumulative fashion. And so that's what kinematic knee is somewhat doing. It's measuring different data points, and thus the actual inclusion zone of the technique we're doing is chasing the anatomical variance better. So personally, when I recommend kinematic, this is what I tell a lot of my colleagues, it's actually very easy to do. In my opinion, it accommodates the anatomical variation better. It is a linked technique, so the cut on the femur will alter your tibia and then your rotation. And there's very few ligamental releases. Actually, I very rarely perform any. And the data, the early data, intermediate data, is showing that subjective and objective scores are superior. Here, this is a paper by Howell. He looked at the 6.3-year follow-up of a kinematically aligned knee, and he found that at 6.3 years, the kinematically aligned group had the same survivorship as the mechanically aligned group. And he also found that the Oxford knee scores were higher, 10 points higher than the mechanically aligned. When we look at a paper by Dossett et al., this group had about 88 patients. They randomly sorted them to either a kinematically aligned group or a mechanically aligned group. And they concluded that all outcomes were better for the kinematically aligned groups, including the Oxford knee score, the Western Ontario McMaster University arthritis score, and the Knee Society score. They also found that they had increased flexion at 2 years in the kinematically aligned group. They were at a higher odds ratio of getting a pain-free knee at 2 years. And in general, the patients walked 50 feet further in the hospital PACU after the surgery. That's not to say kinematic knee doesn't have its challenges and its problems. Certainly within my practice, I've encountered patellar instability. This tends to happen, actually entirely happens in my practice, with patients with extreme valgus angulation greater than 12 degrees, has a history of patellofemoral instability, and possibly this might be caused by the fact that they had a really prominent lateral trochlear facet, which then wasn't replaced by the total knee implant. So when I look at the technique that I currently do, which is called a linked anatomic kinematic arthroplasty, just want to give a quick example. Standard varus knee here. Ultimately, this is what I would have done with my measured resection. I would have put on the medial side, the distal femoral cutting jig all the way down on the exposed bone side, and left my lateral cutting jig high, or at a little bit above where it should be cutting in a kinematic knee. So this was set at 5 degrees for a varus knee, which I typically did. But in a kinematic knee, I do the exact opposite. I actually push down, so I get my untouched cartilage side will actually be the side on the lateral where I'll be pushing down. I'll have a 7-degree resection cut here. I measure my cuts to make sure that I have the appropriate depth in line with what Dr. Howell does with his calipered kinematic knee technique. But then I deviate from there. I use gap balancing techniques to determine my tibial cut, and then I use my tibial cut to determine my rotation. And then after doing a 4-in-1, I double check my tibial cut before making it. And ultimately what I'm doing is I'm determining my distal femoral cut using Howell's technique, but then I'm using gap balancing techniques to determine my tibial cut, and then the tibial cut is then determining my rotation using gap balancing. Ultimately, my results have been very good, and I don't believe this is my specific technique. I believe this is because of the kinematic alignment I'm shooting for. Here's a patient at 2 weeks. You can see the strength came back very quickly, and this is before I completely moved all the way to full multimodal pain. So this patient was doing better because of the technique change. And here's another patient 2 weeks out. This is a right total knee. This is a different implant. This is the Smith and Nephew implant, but I vary between multiple implants. I've used almost all implants, and they've all done relatively well with this technique. Here's what I consider an outlier anatomy. And this is a patient who I had to do a distal femoral cut of 12 degrees. I did a 3-degree internal rotation cut, a 6-degree varus cut of the tibia, and a posterior slope between 7 and 10 degrees. And here you can see the patient did well. The postoperative x-ray, he had his knee flexed, but ultimately he had strength, and he was very happy with the results and did well in the PACU initially. So in conclusion, 15 to 20% of our patients are dissatisfied with the current techniques. Measure resection and gap balancing can be used to shoot for either goalpost, mechanical or kinematic alignment. There is tremendous anatomical variation that we should accommodate when putting total knees, and the intermediate survivorship MPRO's research demonstrates superiority of the kinematic knee at this current time. Thank you.
Great. Thank you so much for that. Do we have some time for just a couple of questions? Could you touch a little bit more on the patellar instability? How much of an issue is it that you run into, and how easy is it to resolve?
So, can you hear me?
Yes.
Great. It is not a high number in my practice. I would say less than 1% of my valgus knees are having this, which is interesting. I don't know why some valgus knees are getting it, some are not. I do believe it has to do with a prior history of patella instability. There really are three pathways, major pathways to getting knee arthritis: medial meniscus, medial compartment disease, lateral compartment disease, and then you have patellofemoral. And a certain cohort of these patients, it's patellofemoral instability that leads to initial arthritis that then turns into tricompartmental arthritis. So I think in these patients, you're dealing with a high valgus angle, but you're also dealing with a secondary diagnosis of patellar instability to start with. When we look at measured resection and mechanical alignment, you have to understand that in patients who initially had 13 degrees of valgus angulation, and you then correct them to 6 degrees because of your set valgus cut, you're essentially doing an intraligamentous osteotomy, which is one of the primary treatments we do for instability, distal femoral osteotomies. And so that's why theoretically we probably don't have the same level of instability issues with total knee techniques which are shooting for mechanical alignment. However, not every patient who has patella instability in their history gets this. Certainly, I do a slide imbrication if I feel the patient's at risk. And other strategies include maybe dialing down a little bit of your valgus angle, or even doing a lateral parapatellar arthrotomy, which I've done in the past as well, and not violate the medial parapatellar ligament, patellofemoral ligament.
Fantastic. And then what's your approach to tibial slope? Are you trying to match the patient's native slope, or do you try to find an ideal slope that you know works well with that particular implant?
Right. I try to match the patient's slope 100%. And so, and I usually match the medial tibia side. And in patients who are burnished or have worn away the cartilage, usually the meniscal roots are still a good reference point for using to matching that slope.
Excellent. All right. Well, thank you, Dr. Sadr. That was an excellent talk.